Our next speaker is an international superstar making his way to the stage. Raul Rosenthal is one of my favorite positive professional role models in SAGES, and he's chair of the Bariatric and Metabolic Institute of the Cleveland Clinic's Weston, Florida, and is going to share with us today belts and suspenders, how I prevent leak. Raul?
Thank you, Kevin. Thank you, Marina. I paid dinner for you tonight with that introduction. Great. Do we have yeah, that we can use. Good morning, everyone. Always a privilege to be invited to present here at SAGES, and obviously a difficult topic, how to prevent leaks. I think if I ask the audience to raise their hands who had a leak, everybody's going to raise their hand, and those who don't, please leave the room. So, because then this topic is not for you. Let's start classifying and understanding why is this important. The rationale is that leaks are a major cause of morbidity, as I will show you, are also a case for mortality, and they result in poor outcome. Patients stay longer in the hospital, increased litigation, and obviously that will result in increased costs. Can we classify the leaks? You know, on my way here, and after attending a meeting last weekend, I learned that we can classify those leaks, and in the past they were acute or chronic. Now we call them acute, early, delayed, and chronic. Acute, I would say, is the leak that you see the morning after, after you did a bypass or a sleeve. You come to see the patient, is tachycardic, is flushed, has shoulder pain. That's an acute leak. The early leaks are those that happen between your discharge and 6 weeks after surgery. The delayed are those that happen after those 6 weeks, and you see them. And the chronic are those patients that come to you after had stents for 6 months, and they still have shoulder pain, and they have this little pleural effusion that you can see that obviously to me that is a leak until otherwise demonstrated. We can classify them depending the type of procedure and site of occurrence. They can happen at the level of an anastomosis, the GJ, or they can happen at the level of a staple line with a sleeve gastrectomy. When we do bariatric surgery, and I think a gastric bypass is the mother of gastrointestinal surgery because you operate all over the place, upper, lower abdomen, stomach, small bowel, and so forth, mesenterium, all the areas of the foregut, midgut, and hindgut might be affected. Regarding the type of procedure, you see that we have procedures that could be resection alone. You guys have a laser pointer by any chance? It doesn't work. Doesn't work. Oh, it doesn't show here. Good. Could be resection alone. Doesn't work either. Could be resection and reconstruction, like a bypass. Good. Like a bypass, or where you work at the GJ, where you work at the JJ. An example of resection alone, obviously, is a sleeve gastrectomy. An example of those that are combined could be like a sleeve plus a BPDDS. I try to put a little bit of effort into this topic because if you search for preventing leaks in the literature, you're going to find nothing. So my apology for not having a reference there. Resections with reconstruction of different segments of the GI tract could be also the BPDDS and the gastrojejunal, jejunal anastomosis. And the question is, why do they happen? Is it because we are bad surgeons? I think it's a combination of tension, ischemia, a combination of, let me go backwards, one more, tension, ischemia, bleeding, distal obstruction. You know, when I practiced in Germany and we had a low anterior resection with a leak, we used to do enemas on those patients. And you would say, hey, how can you do an enema? It was very important for us to dilate that anal sphincter and maintain, the rectum empty, because if there is distal obstruction, that staple line will never heal. And we learned that now with a sleeve gastrectomy in the upper GI tract, that is a similar phenomenon, intraluminal hypertension, a difference in caliber when you reverse a jejunal bypass, and obviously the poor choice of trying to do an anastomosis in a patient with peritonitis. So all these are together the reasons why you might find yourself with a leak, and I think they don't happen separately. Most of the times it's a combination of all of those that come together. Can we prevent tension? Well, there are those who believe that if you go anticolic or retrocolic, you might have less tension, but I'll show you later on that there is no data to support this. How about the omental split? I probably do that once a month, twice a month, that I need to split the omentum, and I always bring my alimentary limb anticolic, antigastric, or creating a mesenteric window. However, the most important message here is that you got to mobilize all the structures when you're going to anastomose, but make sure you don't create ischemia. It's not only about the tension, but if you're going to devascularize that loop of bowel, you're going to find yourself in trouble. Can we prevent ischemia? Well, it is difficult, but if you have a patient that comes after having a splenectomy and you're going to do a gastric bypass, watch out for that fundus, because that fundus might become ischemic. You take away the short gastric vessels with a spleen, you divide medially when you do your bypass, and that tip of the stomach will most likely become ischemic and give you trouble. Or when you convert a VBG to a gastric bypass, the rule of 1 centimeter, you don't want to staple parallel and leave less than a centimeter between your two staple lines, because that narrow tissue area is going to become ischemic. Can we prevent bleeding? And I think this is important, because I always tell the fellows, watch out. When they bleed, they leak. And you see it in the lower GI tract. If you have a patient that passes blood per annum after having a sigmoid resection, to me, watch out for the leak. And if you have a patient that starts bleeding out of a drain after a gastric bypass, I always tell the fellows, keep those drains in. If they bleed, they leak. That hematoma on the staple line at some point might burst, and that's where you got the leak. So the question is buttressing versus oversewing. Make sure you don't stop the bleeding in the OR with electrocautery, because you're going to burn that staple line and you're going to get the leak by definition. Anticoagulation plays a role too, for what I just mentioned. If you anticoagulate the patient and you find that that staple line is going to bleed, most likely you might end up with a leak. Distal obstruction, very important. We just heard the talk from Dr. Galvao. I think the sleeve is a high pressure system. But in addition to that, when you staple, if you start moving the anterior and posterior wall of the stomach while you're stapling, you create a corkscrew, and that will by definition create also distal obstruction and might result in staple line disruption. Can we prevent intraluminal pressure? I mean, there is data out there from Dr. Rubin's group that I was privileged to participate, showing that the intraluminal pressure of the stomach goes from 34 to 43 millimeters of mercury, and showing you that this is a high pressure system. So every time you have high pressure and you have staple lines, this may end up resulting in a leak. How about caliber differences? Specifically those bands that we convert with that intra-abdominal esophagus that is dilated, that dilates that fundus too. Make sure you're careful with that, because that might result in ischemia too. Obviously, patients that are chronically obstructed are a problem, specifically when you want to resolve a JJ stricture and you go for an anastomosis between two dilated loops of small bowel, that might be a problem. Try always to maintain the proximal drainage, and that's the reason we have problems with resections alone. How about tissue healing? I'm sure many here in the audience have heard about that patient that got a leak, and a week later the surgeon takes him to the OR and redoes all the anastomosis. I think that is a major error in judgment. That's my opinion, because you're dealing with tissue that is in the middle of inflammation, it's contaminated. So when you have a catastrophe like that, these patients don't need to die. They're going to need more operations probably, but decompress, divert, drain, and get the hell out there. You know, when I practiced in Germany for 10 years, I was taught in the emergency, the smallest, shortest, fastest procedure. You want to get the patient out of trouble. You don't want to cure the world and resolve the problem forever. Is there any data out there that talks about leaks in gastrointestinal surgery? I came across this nice study from Neil Hyman from Vermont, and they look in a 10-year period, a total of 1,200 operations. It was a prospective collected database. The mean age was 59 years, and the leaks that they encountered accounted for 2.7% of their population. So in gastrointestinal surgery, I would say we're close to 3% of leaks. The interesting part, and if you look at the title of this paper, is it's later than you think, is that the diagnosis was made 12 days after surgery. I always was convinced that these leaks happen in the OR and the patient sometimes leaves the OR predisposed for the leak. But there is something about tissue healing, there is something about bleeding, there is something about our surgical technique or the patient's predisposition for that, and I think they happen later too. Interesting why CT scan had a very high sensitivity to pick up those leaks, and I do believe that CTs in the acute phase are the study of choice, but in most of the cases, decisions were made clinically. They had a mortality rate of 5.7% to support what I told you at the very beginning of my talk, that leaks not only result in morbidity, but they can result in mortality as well. And I was privileged to participate in a study that was published in obesity surgery with Michelle Moore from Tampa, Dan Smith from Emory at that time, Mike Czar, and we looked at a large patient population of patients that underwent bariatric surgery. And these names probably tell you a little bit of what's going on in bariatric surgery, specifically gastric bypass. And you see that the leakage rate in gastric bypass can be as low as 0.4%. Forget about this guy that tells you that never had a leak. I mean, this doesn't exist. 0.4%, but it can go all the way up to 4.3%. This mouse is not working well, I'm sorry. All the way up to 4.3%. And it's not necessarily that this guy is a bad surgeon. He might be choosing to operate in high-risk patients. So we looked at a total of 3,000 gastric bypasses, and we found out that the leakage rate is about 2.3%. Last week we got together 25 sleeve gastrectomy experts, and we looked at probably 13,000 sleeves, and the leakage rate was about 1%, just to give you an idea. But the message is from this study that if patients develop a leak, they create a lot of problems. Look at the group of patients without leaks. They had 25% complications, and the ones that had leaks had 55% complications. And another message that I tell my fellows is, once they become hemodynamically unstable, they become septic, they become dehydrated, they stay for a longer period of time in bed, I start doing duplex ultrasound of the lower extremities all the time, because they're not going to die from the leak. They're going to die from the PE if you're not careful. So it is not necessarily morbidity caused by the bariatric procedure per se and the leak. It's what surrounds the patient that becomes, infected and septic. And you can see here that they had 1% of gastrogastric fistulas, that they had 15% of bleeding, that they have DVTs. Look at the group of patients with leaks. 15% had DVTs that resulted in PE. Obviously, wound infections, many of those were open bypasses, respiratory failure, and obviously the mortality rate of somebody that has a leak is 15%. So I think the key is not necessarily to prevent a leak, but I always tell patients we are good not because we don't have complications, but because when they happen, we go after it and we treat them accordingly. So in all honesty, I think the reasons for the leak, as I showed you at the beginning, are multifactorial. And it is important to check in the operating room if you don't have a leak. But as I show you from the data, they can happen up to 12, 13, 14 days after surgery. So there is no way you're going to keep your patients with drains forever. I'm going to have them methylene blue for the next 2 months. So the question is, and we heard the talk from Greg about staple lines. Does staple line matter? I think it does, but the literature shows us that it doesn't. This was a study showed, with circular staplers at least, comparing 3.5 versus 4.8 millimeters presented at ASMBS by Moore, and there was no difference in the rate of anastomotic bleeding or leaks. It seems to be that you had less stricture with a smaller staple, which doesn't make sense, but that's what it showed. Now, do fibrin glues and sealants help? Well, while Dr. Moore believed it doesn't, Dr. Jones believed that it could. I personally believe that they don't help for anything. How about reinforcement? And again, here the literature, it's a little bit controversial, but I think overall, reinforcement is not to prevent leaks. It is to prevent bleeding. But as I mentioned before, if you prevent bleeding, by definition, you are preventing leaks, because those who bleed have a higher incidence of leaking as well. How about decreasing tension by going retrocolic instead of anticolic? Most of the studies are underpowered. There is inconclusive evidence, and I believe still that we should try to reduce tension no matter how. Circular, linear, and hands-on, same problem. Small studies, inconclusive evidence. Do what works for you. Do what you think is best for you. How about using drains? Well, I'm sure many in the audience think that drains don't help. The only time I regretted putting a drain, not regretted drains, was when I didn't put it in. So I think that provided you understand how drains work, they've been always beneficial. And this is a study we published in obesity surgery looking at drains. And you see the number of patients and how bleeding and leaks are extremely low. The incidence of bleeding on a bad day is about 2% and leaks on a 0.9%. And if you look at bleeding, the majority of the bleedings that we had were intraperitoneal. So I felt the drains are good. I'm not draining for bleeding, but if it happens in the large patient, it's very difficult to pick it up. Is this guy going to bleed into the guts? If it bleeds into the belly, put the patient in the ICU, stop anticoagulation, type and screen, see if the patient is hemodynamically stable. You can work with that drain. It's going to help you in the first 24, 48 hours. And again, since I believe that bleeding results sometimes in leaks, it's good to have that drain in there. And if you see here, these patients needed, in only 50% of the cases, blood transfusion. How about leaks? Well, if you look at the leaks where they happen all over the place, at the GJ, at the JJ, from the pouch. And if you look at the operative treatment of those, only 50% of the leaks needed treatment with surgery. Why? Because the treatment of a leak is drainage, drainage, and drainage. So if you got the drain in there, you don't need to operate on them, provided the patient is hemodynamically stable. So in conclusion, can we prevent leaks? I think that catastrophes usually have some signs that cannot always be seen or identified before they happen. But we should always be looking for those. To me, a patient walks through the door and has a leak until otherwise demonstrated. Before I start the case, this patient comes with a leak. I'm always looking for the leak. Make sure that you look at the history of physical exam. Look for that operative report. Ask for that operative report in patients that had previous surgeries. Reoperative surgery is the present. It's not the future. You guys, we all are going to be doing so much reoperative surgery in bariatrics. So look for that operative report. Rule out possible anatomical changes, and get always a bald guy or a white hair guy in the operating room with you that can help you to understand what's going on. Thank you very much.